Okay, hello everybody. My name is Victor Domenech. I'm coordinator of the Digi4MSK project. Today we continue with our webinar series with the fifth one, and we have an excellent speaker today. He's part of our consortium in the project, Kieran O'Sullivan. Many of you probably already know him. He's a popular professor and researcher, and also a physiotherapist by background. And today, let me share my screen. As I said before, this is the fifth webinar of our webinar series. And it is going to be about supporting self-management for low back pain. I have to say that for this occasion, we are going to change the structure of the webinar a little bit. We are going to innovate with Kieran. So far, we've been doing, we've been following a structure of 30 minutes of PowerPoint presentation and 30 minutes of Q&A. Today is going to be a bit more dynamic, and we are going to try a different structure, and we are going to start directly with a conversation with Kieran. And I will start by making some questions to Kieran, and at some point, I cannot say yet exactly when, I will start accepting questions from the audience. So you are more than welcome to type your questions in the chat. Additionally, for those who want to listen the conversation in Spanish, remember to activate the option in Zoom. Nevertheless, in the chat, our collaborators will type how to do that, or will remind you how to do that. So I'm gonna start sharing my screen. Kieran, welcome. How are you?
Lovely. Thanks, Victor. Thanks for inviting me here this evening. And of course, thanks for leading on the Digi4MSK project, which many people will not realize all the non-glamorous labor that goes into a project like this. And it's been great fun so far.
Yeah. Very good. Kieran, the topic for today is supporting self-management in low back pain. And there's one sentence that summarizes very well the things we're going to chat about today, which is fixing low back pain versus coaching low back pain. What do you mean by this sentence when you say this?
Sure. And I guess, look, like a lot of people on this call, in my professional background, I was trained and raised with the idea that when you got a physical ailment like pain, you needed to get it fixed through some adjustment, injection, or procedure of some kind. And of course, that probably has a role to play in some types of pain. But what the evidence has shown us over, I suppose, a long period of time is that it's persistent health behaviors, exercise, activity, and so on that seem to really drive recovery from pain and staying healthy in general. But this has not been an overnight change, if that makes sense. We are all creatures of habit. And so for many years, with my own back pain and with treating patients, I ended up still adopting that fixing mindset, whether it was fixing their posture, what I thought was their muscle tone, muscle activation, and so on. Whereas what we realize now over time, and again, this is not my original thoughts, this is based on the work of many other people, including my own supervisors and indeed lots of coaches involved in self-management. But what we realize over time is that if we want people to get better, self-management is going to be key to that. But there is a real challenge with self-management in that for a lot of people, self-management can sound like you're being discharged or dismissed off to do it all on your own while I'm going to sit here doing nothing. And that's where I think that coaching piece is critical, that we, to use the language of the NHS in England, it's supported self-management. So we don't want to make you dependent on us, but we appreciate that many people will need some support as they kind of get in control of their health.
So it is not about just letting patients do things by themselves, but leading them and guiding them in this process and somehow helping them to, of course, doing things by themselves, but we have to, as clinicians, understand that they need a learning process, no, to do that, and also change perhaps some beliefs and perspective.
Yeah, like I was teaching students this week, and I was only half joking that when I say that when patients come to see me, they are taking off their shirt, getting ready at the door before we have a subjective history, because there is, a common sense among physiotherapy, chiropractic, osteopathy, that it's mostly about the fixing, the examination and the fixing. And again, we're not trying to abandon all that, but it's a big change in mindset to say, no, first of all, we need a big history. We need to understand lots about your health. And then while I will do some physical things and get you doing physical activities, a big part of this is me doing over time less and you as the patient gaining control. And I got to be careful. We have to handle that. I would love in 20 years' time if everybody understands that. But right now, we have to manage the risk that patients might think we're being lazy and don't want to do any real physical work.
Yeah, yeah. I also have the same impression that when I teach students, when you start the pain course, they have this popular opinion or this common belief regarding back pain about the necessity to fix it. Yeah, is absolutely true. Um, you compare back pain to temporary conditions like tiredness or sadness. Can you elaborate on what this means and for how we should approach treatment?
Sure. I guess I use that analogy quite a lot. And again, it's not my analogy because I read a book by Norton Hadler, the American rheumatologist, many years ago. He wrote several good books, but one of them, Worried Sick, talked about multiple health complaints that aren't any fun. And back pain was one of them. But he described back pain, tiredness, sadness, constipation, and diarrhea as these very debilitating but relatively normal things, in that everybody probably gets them maybe a couple of times in their life. But if you get them a couple of times in your life and they last a couple of days or even a couple of weeks, it's probably within normal limits. And that they are very different from chronic disability. So being sad for 3 days is very different to profound clinical depression. Being tired for a few days is very different to chronic fatigue. And getting back pain for a few days, of course, it's no fun, but that's very different to chronic disabling musculoskeletal pain. And so, without being unsympathetic, what we've probably got to realize is that these are, to use Norton Hadler's term, predicaments of life. Again, no fun, but I would be quite happy if in the whatever number of years I have left in life, say 40 years, if I get intermittent periods of back pain and tiredness and sadness, as long as I wasn't getting persistent chronic fatigue, persistent depression, and so on. The challenge there again is it can sound unsympathetic, but actually what we're trying to do is de-escalate the concern that, oh my goodness, I've hurt my back. Now it's never going to get better because back pain is a rare and scary thing. Whereas all the data tells us almost everybody gets back pain. The statistics tell us it's like something like over 90%. And then we ask, do we really think that the other 8 or 10% never got it? Or is it they don't remember, or it was very mild and trivial?
Yeah, now that you mentioned that after making this analogy, it's very interesting the following fact. It's been investigating a lot. What are the factors that predict the transition from acute to chronic pain? And what do you think is the role of the worrying or the beliefs and the emotional aspects, for example, the stress that patients have during that acute period for explaining those who transition to a more chronic state? What do you think are the main predictors, or if stress play a major role in that acute phase for transitioning?
Yeah, like the evidence tells us again that it's kind of a mix. So at a really basic level, a high pain intensity initially increases the likelihood that it will last. But equally, it is this big mix of, to use that broad term, psychosocial factors. So we often think of the psychological factors, the mood, the stress, the anxiety, but the social factors around socioeconomic status, work satisfaction, relationships, they're all part of that. And I guess, again, in terms of, I suppose, developing a framework for back pain, a lot of it is about asking about as many things as we can possibly think are risk factors, and then acknowledging that the specific risks in your life or mine will differ, But at least if we ask about them all, we can then see what's the biggest risk in your life. Because again, I guess societally, we expect that the risk is going to be about posture mechanics lifting. Like in my university, a research-based university, when they try and do musculoskeletal health information, it's very much ergonomics, manual handling training. And while that might have a role, actual other stuff seems in the evidence to be at least as important in that development of pain or the transition of pain. And any of the studies we've done have just reinforced that sense of there being a cumulative risk. So it's a little bit of a risk if you don't sleep well. It's a little bit of a risk if you have high pain to begin with. But the more of these risk factors that emerge or are present in your life through no fault of your own, the more the likelihood is that this will persist.
Yeah, that's very interesting that you have mentioned now psychosocial factors and also training the physio school. In this case, we are physios, but I think it might apply to other healthcare professions as well. And one factor is that's my perspective. Please let me know what's yours. That we train healthcare professionals, in this case physios, for more classical biomedical approaches, and at the same time they hear or we tell them that psychosocial factors are important, and stress and job situation, how is the initial phase, and all these factors that you have just mentioned are important. But to me, I think that they struggle to grant and take these factors, implement them in the clinic, because they continue with the more bio approach, and they think that they know that these psychosocial factors are important, but in my view, they still struggle to implement them and work with them. How would you recommend them to implement the assessment of them and leading with them in the clinic when they are professionals?
I think it's a really common situation. I think all of us at times have been guilty of saying, well, the psychosocial factors, they make the physical problem worse, but they couldn't be as important as the physical problem. So I think and in the past and many others had the idea that, well, if you have a disc bulge, having fear avoidance doesn't help it. But actually, it's still based on the idea that it's a physical problem and this other stuff is an unhelpful contributor. Whereas I guess with patients and with students now, I will try and get them thinking of scenarios where there is no evidence of physical injury, but you can develop pain. So we'll talk about situations, for example, I'll ask students again this week and next week about things like headaches. So has anybody here got a headache without a physical assault or an injury? And people can clearly identify times of sleep deprivation, stress, maybe a late night with some alcohol, maybe some dehydration, but clear signs of headache without head injury. And then I'll talk about the fact that sometimes my kids will, before school, report a little pain in their belly, and that in that situation, should I be considering that their appendix is ruptured as plan A, or is there equally plausible psychosocial and other stressors involved? Because it's only when we realize, a bit like, again, to use the example of hypertension or high blood pressure, doctors do not differentiate and divide patients into here's the biological blood pressure and here's the psychological, psychosomatic blood pressure. There's an understanding that from genetics to diet to activity to stress, they can all interplay. And so with students, I think it's really hard for them to really sense that it's tricky. And I think there is still a bit of a mismatch between maybe what's delivered in terms of the evidence in a university, but admittedly without the real patients typically. And then in a clinical setting with some really good really good experienced clinicians who might be very good, but probably were trained like me in a different framework. And so there is that bridging point. So for example, I would say now newly qualified physiotherapists, and I'm sure chiropractors and osteopaths are coming out with a more evidence-based view of pain, but they're probably going into a workplace and into a society that isn't quite at the same place. But I'm hopeful at times that we see young evidence-based clinicians qualifying without any clinical mileage and badly in need of that, and then starting to work with very experienced clinicians who might be very effective, but might actually be misunderstanding how they're effective. So for example, I think there's lots of people out there doing great stuff with exercise for people with persistent pain, and maybe thinking most of that is physical and structural, whereas actually when we start looking at even how things like exercise help, it looks like over time, it's a lot to do with systemic effects, reducing stress, enhancing sleep, helping mental health, and so on.
Yeah. And yeah, we have just talked about how do we change the perception of students of, in this case, physio students or healthcare professionals in general. But regarding public perception of how we should treat low back pain in this case, how do we shift from more bio approach towards more self-management and coaching approach? How do we deal with the public perception? Because uh, I know that this situation is different in different countries or European countries, but for example, in Spain, my country, most of the physio clinics are private and they have to deal with clients demanding certain things. So how do we deal with these patient expectations or public perception of how low back pain should be treated or managed?
Sure. First of all, I think we cannot pretend that that's easy. There is clearly a mismatch right now. And you can adopt two extreme positions that I disagree with. One is, well, the patients aren't ready, so we just give them what they want. I don't think we can justify that. But then equally, we must force patients against their will to comply with a thing that doesn't make sense to them. Whereas I think there's a middle ground where we can hopefully nudge patients in the right direction. And again, I think a critical part of that is establishing that patient therapist interaction. I might have lots of good ideas and you might have some great knowledge, but the first thing is getting the patient to understand I genuinely care and I'm taking their problem seriously. And my experience is that if a patient really feels, Victor is listening to me, they seem quite comprehensive and thorough, they're taking the time with me, then even if he's saying some things that sound a bit strange, I'll be willing to give them a go. But that's, I guess, in the clinic. Where you're probably really going is how do we change that in the long term? So, for example, I would love by the time I'm retiring that patients, when they come with pain, have an understanding that it might have a coaching focus, a self-management focus. And I guess I see there being two big parts to changing public mindsets. Number one is education, and I still think public education has a role, but I'm a bit less optimistic about education in its own right. So there's been a few studies done. Rachel Bushpointer in Australia did one, a public health campaign on back pain, and it showed a small but encouraging effect. But what's interesting is other countries have tried replicating those studies to change, like radio ads and media ads, trying to change public mindsets. And there's some great work done by Lorimer Moseley in the Pain Revolution and Cormac
Australia.
Ryan and Flipping Pain. So really great initiatives that I'm fully in favor of. But I think and so I really want more of those in Ireland and Spain and everywhere else. They are positive. But I guess what we know from most health behaviors is that education alone is rarely enough. So to give you an example, in Ireland, the alcohol companies and the gambling companies want public health initiatives to be only education. So have a drink awareness campaign, but don't tax the alcohol, and have a
Yeah.
gambling awareness campaign, but don't add taxes to that. And I guess when we look at changing public behavior around healthcare as well as the education, changing the incentives looks like it's a really important part of that as well. So in many countries right now, if you've got a painful degenerative knee, your government or your insurer will cover the cost of an MRI, which you mightn't need, and will cover an arthroscopy for your knee, which probably isn't going to be effective. But actually, if you needed significant supervised self-management with access to, say, a physio, a dietitian, or a psychologist, or some mix of those, it would almost certainly be less funded or less refundable and less accessible, if that makes sense. And so if we want to change the public mindset, I absolutely want people to get the big picture message, the holistic, all these pieces are part of the jigsaw. But actually, we have to make it, I would argue, more attractive and cheaper to go for the evidence based option. But actually, the challenge at the moment is it's often less affordable, less accessible to try and find a supported self management space. It's actually, well, my government or my insurer will cover the surgery, the injection, the scan. And so to change those mindsets, that's where I think I've ended up for. I still think the education's a piece, but I think I'm not a politician, but I think we need political influence in terms of physiotherapist representative bodies, patient representative bodies, arguing for not for any one profession, but for access to the stuff that works. And in this case, that will be exercise informed, psychologically informed self management.
Yeah, so it is a combination. No, there must be political actions and also some interventions in the healthcare system, and also individual clinicians in the clinic doing education and changing approaching, etc.
And sometimes, as an individual clinician, we're going to focus on what we can do in our clinic and our community. But then, obviously, at national levels and international levels, we need to have organizations that can advocate for that. And again, it's tricky there because sometimes that can turn into, well, am I advocating for physiotherapy or dietetics or psychology? But actually, there is a need for more allied healthcare professionals supporting people with chronic disease in general. And unfortunately, we have never had the funding of some of the big pharmaceutical and medical device companies.
Yeah, of course, I have nothing to do either with politics. I'm not a politician. I'm just teaching at the physio school. I also see patients and I do some research. But just to put one example of what we can do or what I do in the clinic that might help changing the approach. When I have a patient in which I suspect it's a patient with chronic low back pain, and I suspect that there might be nothing specific and nothing to fix, and we want to go for a more coaching-based approach, let's say. One thing that works for me very well is just to make a very thorough examination, a clinical examination, so that I can demonstrate with data and with something I have done in the clinic that perhaps there's nothing to fix. I have observed that with clients, this is very powerful because they see that you are not biased towards any specific approach, that you just consider all options, and that you make a very thorough examination, both clinical examination and also the history. You take the history very thoroughly, and I think this is a very good way to get to make patients trust you as a clinician. I think, yeah, it's just to add an example of how we can implement this.
I think it's true. There's been many studies done in many countries down the years asking people what is a good back consultation. What differentiates a good doctor or physiotherapist for your pain compared to another one. And a lot of them come back to the Norwegian study many years ago, where they found things like taking the person seriously, whatever that means, and examining them properly were critical indicators of a good consultation. And I think that very thing you said about subjectively being very comprehensive and even objectively being very comprehensive. The late Max Zussman, who taught me many years ago at Curtin University, was at times quite critical of lots of the fixing mindsets that physiotherapists had. But he always emphasized the importance of a good physical examination as part of, and this was his word, the ritual of an appointment. In other words, it's something that people come in. And I would still see the value in that. So even if I see a person who I'm very sure manual therapy as a treatment will not be a big part of it, I still see a big value in physically examining, putting my hands on them, to reassure them I'm not missing anything, I'm not skipping anything, I'm not forgetting anything. And then once we've looked at all these factors, isn't it interesting that these things seem to be present? And let's talk about that. So thoroughness. Yeah. And I appreciate that's hard with time, but I do fully agree with you.
I'm glad that you have mentioned this study because it was just my own personal experience, but it is supported by science. Yeah, I think we see this quite a lot with the example of sciatica. Many patients come with the idea that they have sciatica, but you test for negative signs and conduction seems pretty well, and there are no signs of mechanosensitivity in the nerve, just some backache and perhaps referring a little bit through the pelvis, but nothing serious. And you say, oh, I have tested this, your cables in the nerve seem to work very well, and I have stretched your nerve and it hasn't hurt it. So I think that your nerve is essentially okay. So now you open the door to go into another perspective, and yeah, that's
we still I do it like so. We still divide things into these sections: subjective, objective, treatment in our assessments. But I would argue if you talk about somebody like that where they are worried about sciatica and a trapped nerve or whatever the term is, the ritual of checking the reflexes, even if it's quick, it only takes 15 seconds. But I think what's missing sometimes in many clinics is we do the reflex, but an average person does not know. Is that a good thing or a bad thing? Is it normal? And actually just the real basics, because again, that comes up in those studies. being properly examined and having it explained to me what they are doing and what they found. So doing a reflex, that's good, that looks fine. And that looks good, that's fine. And almost kind of communicating what we're doing, that we're not in any way, again, not dismissing, but we are examining, confirming, and reassuring.
Exactly. And but sometimes, I don't know if it happens to you, but I think it's quite common that when you do this clinical examination, after that, they tell you, oh, nobody has to spend this time examining me and taking this time to make a thorough examination. So thank you very much. And to me, it seems that for the patient, it means that they recognize that you take them seriously and that you value the clinical encounter and that you, as I said before, consider all options as a potential diagnosis.
Absolutely. And again, I appreciate it's hard in a busy clinic to have enough time, but I do think that is one of the reasons why students often get really positive feedback from patients, because they have an hour, sometimes an hour and a half to take a detailed history, take their time, do probably far too many tests that you would not need to do, but they want to practice them, if that makes sense. But again, it gives that patient that sense of they are taking their time, they're not missing anything, they're giving me a very comprehensive examination. And that in itself is reassuring, because in today's healthcare, especially in some countries, 10, 15-minute appointments are not uncommon.
No. And Kieran, regarding yeah, pain clinicians often see patients with a diverse background. However, most studies, including those investigating the importance of digital health literacy, which is, by the way, something very important in our Digi4MSK project, are conducted with Western and individuals with high literacy, with not definitely very diverse. So, what do you think? How do we deal with this discrepancy between studies and reality in the healthcare systems?
It's a huge issue, and we see it in almost every healthcare condition. Just this afternoon, before this call, I'm on a call with students about a systematic review looking at teenagers with back pain. Lovely studies, but overwhelmingly white, middle class, with highly educated parents. And it's not that we don't want to treat them, but it is a certain section of society. And I guess, look, it's complicated. I think it depends on where we're, first of all, finding our patients, and where we're then obviously connected to that, what countries we're testing in. But we definitely see more data from high income countries, and within those high income countries, the high income areas within those countries. So where my university is, for example, is one of the more affluent parts of Limerick, even though that's a working class city. And changing it is hard. But for example, what we can, I think it has specific relevance to self-management, because without trying to judge or criticize anybody, we know that if you are from a high socioeconomic status, highly educated parents, a little bit more affluent, social or self-management is easier. You have more resources, you have more money to access resources if they're privately available. You have more confidence about putting your hand up and seeking out resources. And so one of the challenges for people like us who are in favor of self-management is making sure that we don't end up with increasing the divide, if that makes sense. And this divide occurs in terms of accessing physical healthcare, but also in terms of digital health literacy. So if we step back a couple of things, we know there is this disparity between the complex mix of people we see in clinic, where there is definitely going to be a more diverse and on average less advantaged population than we see in the studies. And then that while the evidence would tell us we need to not intervene, not be trying to fix in the old mindset, but we just have to be careful that self-management doesn't get interpreted in these groups as just saying, here's a leaflet and off you go.
Exactly.
It is hard to reverse those things, and we're doing small bits of work, like lots of research groups, to talking about trying to have community and patient and public involvement. And that's really, really good. But even if you look at the lots of those patient involvement groups, overwhelmingly they tend to be, I suppose, have memberships from the higher income members of society, who have the time and maybe the education to be involved on these committees, if that makes sense. So I think we're aware there's an issue, but even in terms of digital health literacy and online campaigns, we have to make sure that's accessible in the diverse languages. And I guess particularly thinking about who the messenger is. So if you've got somebody who's a migrant from Africa in Ireland, For sure, I can give a talk and it can be translated. But ideally, if we really want to change beliefs, it probably has to be, a person from that background, ideally with that language that can communicate. I know when I went to Qatar, working in the Middle East for a few years, there was definitely some situations where, first of all, I might have been flat out wrong, but secondly, where I wasn't seen as credible, even if I was right, because I was coming from a very different mindset. And that's just the complexities of life.
Yeah, I guess this cultural adaptation is crucial because I recently read a paper published in Musculoskeletal Science and Practice that was based in a very big survey conducted in Canada, and one of the conclusions was that more and more patients with musculoskeletal disorders are asking for exercise and are happy with education, etc. But perhaps we will have to consider what the cultural background and socioeconomic status, etc. Because I guess that it is different depending on both the country and the social sectors, etc.
And again, we're all like you and I might like to think our beliefs are so mature they are not influenced by the fact that we grew up and live in Spain and Ireland. But of course, our environment and our background affects us. And even if we look across Europe, I won't get into naming specific countries, but I can think of some countries in Europe where there is much quicker access to imaging. And when those people move to Ireland, they expect MRIs almost immediately for back pain, even if they're not indicated. And so it's a real challenge. That's a very different mindset to what would be common practice here.
Yeah, exactly. Very good, Kieran. I think I'm pretty happy how the conversation is going. I think many interesting questions have been discussed. If you're okay with this, we are going to make some questions from the audience because I see that some people have posted their questions. We still have some time for making them. So one is from David. He says, would you agree coaching is the bridge between dependence and independence if it creates interdependence? I don't know if I get this question.
Yeah, I think that's it. That what and the idea of it as a bridge, I think, is exactly right. That we are again, I appreciate that some people will need very little coaching and bridging, that they will be ready to hit the ground running, and other people will need a little bit more. And I appreciate there's a subjectivity in that. But essentially, we are all agreed about the destination, and the destination is long-term managing your own health and then popping in and out for healthcare as needed. So I think we can learn a lot, for example, from things like the management of COPD and diabetes, where these are chronic conditions. We are not talking about cure. They are primarily self-managed, but we do not see a person with diabetes, let's say in 18 months, having to go back to check something with their GP, tweaking their medication or their diet a little bit, and then going back to the community. We do not see that as a failure, or somebody with COPD having an exacerbation. We understand that happens. Whereas with pain, and I see lots of patients where they will say, I had back pain, I went to physio, I tried it, it was great, but then the pain came back, so the physio failed. So now I'm going for surgery. Whereas actually that person, obviously we would love if pain never came back, but it's probably likely the pain is going to come back at some point. But hopefully before it escalates and become too disabling, they can have access to some support. They mightn't need it, but access to it, a bit like the diabetes and COPD. Can I tweak something, readjust something in my lifestyle, my health, and then get on that rhythm again? So again, here's where healthcare becomes tricky. In Ireland and many countries, managers will have incentives, kind of performance indicators. You must discharge so many people within a certain amount of time. And that might solve one problem in terms of the number of patients on your wait list. But what we've seen from, I suppose, observing the fluctuations in pain and even the Restore trial, where we gave them all a 6-month booster, is that there's sometimes value not in treating people all the time, but having them come back at an interval into the future, either structured, like come back in 6 months, or come back anytime in the next year when you have a problem. So that we're not going to make you dependent, but you can access us without having to go right back to the start again.
And regarding these analogies with other illnesses, such as diabetes or chronic fatigue, etc. Do you recommend clinicians to use these metaphors or these analogies in the clinic? Do you find them useful in the clinic, or it is just for educational purposes to other clinicians?
That's a really good question. So I've never thought about it. What I do talk to clinicians and students about, and I recommend they talk about, is things like headache and high blood pressure. And I talk about cold sores and eczema, so skin conditions, because I think they are very, in the public mindset, closely connected to stress and sleep and being run down. So they're easily transferable. I don't know why. I don't think I've actually used the diabetes COPD as a here's an analogy you should use. I think for me, that's a little bit like Lorimer Mosley's wonderful stuff on explain pain and pain biology. I have listened and learned an awful lot from that, and it has helped my understanding in communicating with patients, but I don't actually use those terms with patients myself, if that makes sense.
Mm-hmm.
But I guess they could be. Do you have any sense yourself about any pros and cons? Because in a certain person, diabetes might be a more scary condition, you know?
Yeah, in my experience, I have used. It is good because I have never reflected on this, but I use sometimes these kind of metaphors for teaching purposes at the physio school, but not. I don't do that as much in the clinic because, for example, when I try to explain or contextualize why education or improving health literacy matters with patients, I use, for example, the diabetes example, when we have to teach patients what is insulin, what is glycemic index, etc. No, they need to know that in order to keep their health. No, it is basic. We don't just ask them as patients to take metformin or insulin, etc. They need to know. They need to be a bit more knowledgeable with their condition, and that's a reason I use with the students so that they understand that improving health literacy in patients is important. But as you said, I probably don't do that as much in the clinical context, and it might be useful, yeah, to compare that sometimes a condition might last for a long time without it necessarily being very, very serious or being totally okay to do your own life and continue with your activities, doing exercising, etc., despite the illness.
If I could think of one audience where I would really like them to hear that message, it would probably be the people who design our health services. Because I think we offer too much of an acute care model to things like persistent pain. So there's a sense of you will get seen, we will give you lots of treatments maybe for a period of time, but then you have to be discharged. Whereas I would much prefer we would, yes, see them early, but maybe not see them very frequently, but keep in touch and supervise them over a longer period of time. Whereas if those health service managers or insurers say, no, it's a 6-week program and then you're gone, that's an acute care model, which has a role for sure in some parts of healthcare, but I really don't see it being a big part for chronic musculoskeletal pain.
Okay. We continue with questions from the audience because I think that we have many questions, Kieran. Well, Martin says that he lives in the Czech Republic, where the physio culture is very based on biomedical model. He says that he's a newly graduated physio and he sometimes struggles with how to approach patients when he tells them there's nothing wrong with you, and the posture and other factors probably don't matter as much as they thought or they led to believe. Why will a patient trust Martin over a more experienced physio, and how he should handle this situation?
Yeah, good question, Martin. And again, it probably comes back to something you said earlier, Victor, about the mismatch between what patients are expecting culturally in terms of their beliefs and what we think they need. It's rather than telling Martin what to do, I can tell you the ways in which I've got this wrong. Where I've got this wrong before was being so much in a hurry to tell people the correct information that I rushed it and I didn't give them a chance or long enough to tell me all their story. And so, sometimes we want so quickly to give them the right exercise and the education that we don't give them enough. So a big part of it for me would be just remembering to let them talk for a long time, tell me all the story, and then, as much as possible, before I tell them, try and help them to connect the dots. And so we use timelines a little bit for this. And again, this won't always work, but it can be in the history. Let's say it was 2024. And they identified flare-ups in their pain in March 2024 and say August 2024, and they were the increases in their pain. And when we in their history we will establish, was there triggers, and they will of course first go to the physical triggers. Oh, I was sitting more, or I lifted something that time, and that might be true. But then if we have a separate conversation about, talk to me about your work, your sleep, and does that ever change? That can often be a time when we identify, well, actually, they won't have thought about it, but actually last July, August, there was exams, there was a big project. And in March, I had a really bad flu and I wasn't able to get out and exercise. And it's often then that it's only by getting them to see, oh, well, that's at least it's interesting that those flare-ups, there was a physical trigger, but it's interesting that it seems to be on a background of other stuff, if that makes sense. I think it was Bob Pike had the general principle that people don't argue with their own data. So they might dismiss the general idea that stress causes pain, but if they can identify that their pain is linked to it, that might help. But I hope that gives some clarity, but I would still completely accept that doesn't mean everybody's going to be ready for it. And obviously, what would make Martin's life easier was if the GP referring that person had primed them for that and had a little bit of this discussion. And if that person going back to their employer, they already had a sense that there was a range of factors that were involved.
Yeah, very good. And Seila is asking if this, for example, this coaching-based approach might work better individually or in groups. Do you have any ideas on this or any experience you can share?
I think, yeah, I can tell you some opinion and some data. I think it can work in both ways. There's been very few, I think actually only one trial showing this approach being tested in an individual or group setting, and that was Mary O'Keefe's trial that we did in Ireland, and Mary's involved in this project. She's now in UCD. And that showed in that single study that the individualized approach was better. Now, there's a whole series of reasons why it might be better, a bit better in the individualized approach. It could be the time alone, the attention, but it also could be the ability to tailor the intervention. What I would say, because I often get asked this about, like, should we be doing telehealth or in-person, group, individual? I would say I'd like to offer them all. We are not going to run out of kind of options or run out of patients anytime soon. But it would probably be great if the main messages were consistent throughout those. So if you're going for a telehealth class for your chronic musculoskeletal pain in Zaragoza, or you're going to an individual treatment, or you're going for a group class down in the community gym, that the exercises might change, the little things might change, but the overall emphasis around self-management, biopsychosocial model of health, and like basic things. It's not your fault. It's understandable that it's frustrating. Mm-hmm. These key messages are the same. But my bias would be individualized. You can do it a little better. The reason I'm still open to quite a big role for telehealth and community-based group rehab programs is we have too many people. And so I would love to be able to offer them all one-to-one care in a very individualized, supported way. But if we do that, the waiting list could get bigger and bigger. And I think in the short term, lots of people are just getting no care. So if we get broad, sensible messages into group settings, telehealth settings, reaching remote populations, great. And it's not quite the same message, but Karen McCreesh, who's a colleague of mine at the University of York, she's doing a project looking at group exercise for community, for people in the community for chronic pain. And it's not even physios she's using to deliver the message. Cormac Ryan and Karen and myself have done some training with these personal trainers, essentially. And they are doing these exercise classes for people with pain. Not because we want to replace physios, but what we want is we want everybody giving similar messages, if that makes sense.
Yeah, and what I take from what you have said before is that even if we go for the group-based approach, it is crucial that the patient perceives that there is value and organization behind the approach, even if it is groups, because if the patient perceives that we are just, or the healthcare system is just trying to get rid of patients because of the lack of time resources or healthcare staff, etc., adherence and trust might just drop, no?
Yeah, and it's a really good point, because the whole treatment is contextualized is important. So for example, if somebody is sent for physio because they can't get surgery for another 3 months, that totally changes the purpose and the value of the physio. If it is only something that is just to keep you occupied while you are waiting for the real treatment of surgery. And in the same way, if somebody's going for group rehab and they see it as this is the thing they give to poor people or people who don't know the bosses or who only in the public sector get this, that obviously is going to make it a little bit more challenging. And even down to in group settings, making the physical space attractive and safe. Going back to the socioeconomic disparities, often you will have beautiful leisure facilities and swimming pools and parks in some parts of the city, and other places just won't have the same nice, attractive, safe spaces. And so I can't pretend that I have the answer to these things, but they're worth considering.
Yeah. Matilde is asking, well, many people is thanking you for the great talk, Kenan. And she's asking that when you say coaching, what would be your definition of good pain coaching?
Sure. And again, look, not my own definitions. I'd really have to talk about coaches like Pete Moore and obviously people like Peter Sullivan and those who have mentored me. But I think it's one of those things that now the word coach is thrown out there, that it can be a little bit vague. Like there is every kind of lifestyle coach on Instagram, I'm sure, these days. But for me, I guess the key things about good pain coaching, I would say, first of all, is that they're a good listener and they ask about loads of things, a bit like your comprehensive thing, first of all. So coaching, we often think about, like I coach children in sports, what we're going to tell them. But actually that whole thing of a good coach is a good listener. So listening attentively and showing them that we're listening and asking about lots of things. The second thing I think about, because we're here talking about health promotion and lifestyle, is to not be too preachy. By that I mean, in terms of whether that word translates, I shouldn't be saying, now, Victor, I am a wonderful, healthy, good person who doesn't eat chocolate or doesn't drink beer and doesn't smoke. And you have pain, and it's because you're a terrible person who drinks and smokes and doesn't exercise properly.
Yeah.
So that sense of, I really think it's important. And again, if you think about it, even the fact that I'm now a balding middle-aged man, I don't look too healthy and young, but you could almost sense the risk of a 25-year-old who's never had a pain in the rake almost being too enthusiastic and not being taken seriously. So going back to that, the really good listener, that sense of strongly recommending what can make a difference, but not with the message that you're a bad person for being caught like this. And I guess the third one where I've really struggled with is maintaining optimism and patience when it doesn't all get better quickly. So I would love to tell you about the story that this person came in, they'd lost the confidence to move, we got them moving, and it was great. In reality, there's lots of ups and downs, and person tries the exercise. It worked for a while, but it got sore. Then they got scared. We had to try a different exercise. Then their project worked, so they weren't able to do X, Y, and Z, and job stress went up. So it's that last piece around, as well as being thorough in your examination, otherwise not being judgmental, having the patience to manage the wobbles and not lose faith, because many times it is not plan A or B or C, but it's plan D. And even though we know where we're going, who was to know that actually it was the men's shed down around the corner that the older retired man would meet friends and do physically interesting stuff? Who was to know that that would be the thing that got him back physically active and engaged in life and so
on? Yeah. Francesco is asking for papers talking about coping strategies or skills regarding pain flare-ups in the musculoskeletal field. If you could suggest some, maybe we could collect afterwards some, if you cannot come up with some specific ones now, or and send them out.
Just off the top of my head, I would always recommend the pain toolkit stuff by Pete Moore, the pain coach, on managing flare-ups. That's really solid stuff. And I know even in
that's
the last
a course,
while,
no?
Yeah, it's a course, but he's a whole website and lots of free resources up there. And then Bronnie Thompson, who's an occupational therapist in New Zealand, does some really nice free online materials around flare-ups. Because again, I think with the flare-ups, there's the two parts. Here's the strategy I'm going to use. But I always think with the flare-ups, will I even remember the strategy when I'm having a flare-up? Even if I give a person a plan for your flare-ups, when the pain comes back, they can sometimes panic so much and get so frustrated that they mightn't even realize I had that thing on my phone or the leaflet about managing my flare-up.
Very good. Mari is asking regarding another population with carpal tunnel syndrome. She says that she has worked with patients who were going to undergo carpal tunnel release before they were referred to the physio clinic. Most of them didn't fully understand their condition, how to manage it, or how to cope with it. The only option they had been given was surgery, with the belief that more conservative treatments couldn't solve the problem. She asked, how do you address these beliefs? No? How do you encourage patients to take a more active role, I guess, before getting into the surgery directly?
Like, I guess I really don't know much about carpal tunnel syndrome, but I guess the broad principle there of somebody going for surgery before they've fully tried and been unsuccessful with rehab is common in lots of aches and pains. There's probably a lot of different things. There's, again, the big broad perspective of patients expecting surgical biomedical treatments to be highly effective. There's, even in a given country, in Ireland or Spain or anywhere, do the health system and members of the public value that profession? Is physio or whatever your profession is it taken seriously in the profession and trusted? And that's where, the importance of standards and post-grad training is part of it. And then finally, I've touched on it before, this makes me sound like I don't want to pay for any surgeries, but almost that sense of making sure that the incentives are aligned with the evidence. So if it's an evidence-based rehabilitation program, is that funded as well as this might be an evidence-based surgery? I'm not familiar, but we definitely have pockets of things that are insured and covered by governments just because we've always done that.
Very good. I think we have one more question, and Tingre is asking the following. Happy to practicing cognitive functional therapy for some time now, and also venturing into psychological trauma. A slow but steady rise of a caseload among low back pain patients with different levels of traumatization or autonomic dysfunction due to stress levels seems evident among the more complex cases. And is asking any comments on trauma-informed supportive care for low back pain patients.
Great question. Yeah. So again, a really great question. And I'll give you some ideas, but it won't be based on any great evidence, if that makes sense. What I would say is that over time, as we ask more about these psychological factors, we see more of them and we see a greater spectrum. And I guess on one end of those, we'll put the easy yellow flags of people who are afraid of moving. Because I would argue, if you're afraid of bending and lifting, there's probably no profession better suited than physios in terms of giving people physical confidence to recover the ability to bend and condition them, if that makes sense. And then there are, over time, then, because of the evidence for exercise, I think still quite a role for physios and other allied professionals using exercise as a means to manage mild levels of stress, anxiety, and depression. It's an evidence-based approach for mild levels of stress, anxiety, and depression. But then as we get into more significant mental health problems, there's a student of mine, Julie Sugru, she's a physiotherapist in Ireland, and she's doing her doctorate on physiotherapists identifying orange flags, so specific depression and leading into suicidal ideation. And while that's different to trauma, again, it's a distinct group. These groups definitely need more psychological support than just we're getting over a fear of movement. And I think, for example, the role of the physio at the start might just be identifying. Just identifying it is a great start. And in a non-judgmental way, communicating to that person that I feel as part of your treatment, dealing with your trauma is really important. I don't have data on trauma informed supportive care with back pain, but Michelle Sterling has done some nice work on neck pain, looking at stress mode X, wasn't it? Yeah. And that's probably, but Victor, you might have more, that's probably the closest thing I can think of. It was like a stress inoculation kind of a description. And again, I'm sure there was some training involved and some extension of scope of practice. But I think there is probably at some point in time where you're definitely going to need clinical psychology input. But again, in reality, in the average private public practice in Ireland, those clinical psychologists are not accessible. So identifying, I think, is really good. Communicating that it is relevant is really good. And then at some point in time, there'll be parts of that, like stress modics, that physios can help. And then at some point, we need those allied health professionals. And so again, I think we don't need clinical psychologists, for example, to deal with fear avoidance, but we absolutely need them to deal with the significant levels of distress and depression and trauma we see in some people.
It is crucial to screen for mental health, because the more there are studies demonstrated that the more widespread the pain, the more associated it is with other comorbidities, especially mental health disorder, mental health illnesses, and also metabolic disorders. So the more chronic and the more expanded the pain, the more likely it will be for patients to present these comorbidities. So it is crucial and very, very, very interesting question. So Kieran, very good. I think this is pretty much it. We are, time is up now, and there are no more questions. So I think we have nailed it. It is almost 8 in Spain and almost 7 in Ireland. I'm going to share my screen to just say last couple of things to the audience, which we thank a lot for their presence and their attendance to this conversation. We have tried this new format, and I think it has worked very well, no? Don't you think that, Kieran?
Yeah, like I'm more than happy if it saved me putting people to sleep with PowerPoint again. I think that's all good.
Very good. Well, so last, I encourage the audience to participate in our ideas contest. We are looking for creative and new ideas regarding how to promote self-management with patients in the clinical context, and also how do we deal with patients' misinformation, or in other words, how we take care of patients' health literacy, and how do we improve this. So you can follow us in the social networks. We are pretty active in Instagram. We post weekly, and you will be able to find more information regarding these ideas contest in the social networks. Finally, if you don't mind, we will really appreciate if you can complete this survey, this satisfaction survey regarding the webinar. For us is very important. You have here the QR codes for completing it in English and also Spanish. So we're going to leave these QR codes a little bit more, just a couple of minutes or so. Kieran, thank you very much for your time. I'm very satisfied. I think it has gone very, very well, and people have thanked you several times for the responses you have given.
Lovely. Well, thanks again, Victor, for the invite, and again for leading on this project and making my life so easy and smooth with it. And if people have any questions, by all means, they can come back with emails. I will just type my email in the chat in case anybody had any follow-up questions when they couldn't understand the Irish accent.
Maybe I will. We can also type in the chat for a couple of minutes more the link you sent me before the webinar regarding more information about coaching and coaching versus fixing, and also some summaries about the Lancet studies, etc. And there are also some audios when they can expand, when they can get more information regarding the topics that have been touched here. So maybe Mar or Julia can help us and can introduce this link to the chat so that the audience will be able to check them. Kieran, thank you very much for your time, and see you soon.
And yeah, hope everybody's a good evening. Take care. Bye.
Take care.